Hello, everyone. This is Tuesday, April 21st. I'm Justin Witt, Program Director of the Ball Family Medicine Residency, and today we're going to talk about NSAIDs, which, when, and how much. I'm glad you're able to tune in today. This is a recorded version. I actually forgot to record the first version, so this is take two, and those of you who are on Night Float and were not able to tune in, you'll be able to watch this recorded version. And I'm going to share my screen now, and then we're going to get started. And I wanted to start off today with a case presentation just to get our clinical wheels moving. So here is our case. We're going to talk about Mr. Jones. Mr. Jones is a 63-year-old male who comes into your office for chronic joint pains, mainly in his hips and knees. He has tried all of the over-the-counter medications available for pain, including Tylenol, naproxen, ibuprofen, and he says that those have provided minimal relief. Your history, exam, and available x-rays are consistent with osteoarthritis. What do you recommend at this time? What information might help you determine your next steps? Some key questions might include how much the pain is limiting his activity, prior dosage, consistency, and duration of medications, and whether Mr. Jones has any history of GI or heart disease. How might you treat Mr. Jones' arthritis pain? Well, I hope that our further discussion today will help you answer that question a little bit more. Let's jump into the case for NSAIDs. I shared a quote with you from Sir William Osler. "This is our work, to prevent disease, to relieve suffering, and to heal the sick." So paramount to our relieving of suffering oftentimes comes in the form of relieving physical pain. And NSAIDs have been shown to help reduce pain and inflammation for numerous acute and chronic conditions. So these are medicines that are particularly helpful and useful to you in your day-to-day practice of family medicine. A 2009 survey was conducted by the CDC and showed that analgesics were among the most commonly continued or newly prescribed medications in an ambulatory office setting, which occurred in over 11% of those visits. 2018 data shows that 128 people die each day in our country related to opioid overdoses. So our quest for relieving suffering has led us down a path of prescribing opioid pain medications for non-cancer, non-hospice related pain. And that has resulted in a crisis of huge proportions with the current opioid epidemic. And we obviously want to prevent that from escalating. So we have a pretty strong impetus to prescribe non-opioid pain relievers. So what exactly is an NSAID? NSAIDs have been around since the 1960s. Aspirin has been around since the mid-1800s, but other NSAIDs were developed in the early 1960s and some much more recently. There are multiple NSAIDs available, and they differ on their chemical structure. All of them block cyclooxygenase enzymes. To date, there are two known cyclooxygenase enzymes. We name them COX-1 and COX-2. It is widely believed that COX-1 leads to the body's renewal and mechanisms of protection, such as mucous membranes and the lungs, while COX-2 drives inflammation. Although I don't believe that it's that clean or precise within the body systems. All of these agents can vary in their mechanism of action, their toxicity, and how the body processes them. I include this slide with the different chemical structures, hopefully not to overwhelm you, but just to show the incredible diversity of chemical structures available within the class of NSAIDs. Some of them are much more complex than others, and so as you can imagine, these all have slightly different effects within the body. You can roughly classify NSAIDs into 6 different buckets, which I've depicted here. And the first on the top left is the category of salicylates, which includes aspirin. Now, we won't be really talking about salicylates today. Aspirin could be a lecture in and of itself. I'm going to focus a little bit more on the other non-aspirin, non-salicylate NSAIDs. As you can see, ibuprofen and naproxen are both fall in the same class of NSAIDs, which are propionic acid derivatives, along with several other members. There are also several members within the acetic acid derivatives, and the other classes have just one or two. As you can see, the selective COX-2 inhibitors down on the far right list just one member, which is celecoxib. And in the past, there have been other agents marketed in that box, but they've been withdrawn from the market. So this whole COX-1 versus COX-2 thing, this is loosely depicted in this graphic, which shows that certain NSAIDs fall farther toward COX-1 selectivity, while others fall toward COX-2 selectivity, and some fall in the middle, like ibuprofen is pretty balanced in the middle. So it's going to stimulate or block, it's going to block COX-1 and COX-2. This becomes important with regard to its effects, side effects, and GI toxicity, and we're going to talk a little bit more about that later. So all NSAIDs have a ceiling for the analgesic effect, not necessarily to the anti-inflammatory effects. So this means that as we escalate the dose, we're going to achieve a dose at some point where we're getting most of our pain benefits. And if we go beyond that, if we continue to increase the dose beyond that point, that we're going to get more side effects, but not necessarily more pain relief. NSAIDs are typically more effective for conditions that are mediated through prostaglandins. And these would include osteoarthritis and dysmenorrhea, just to name a couple of examples. However, NSAIDs are associated with more side effects than acetaminophen, and some of the most common side effects include headache, drowsiness, nausea, and indigestion. There are many drugs that have interactions with NSAIDs and that we want to avoid use. Just about the only drug that's universally contraindicated with NSAIDs is another NSAID. There are medical contraindications as well, such as hypersensitivity, anaphylaxis reactions to NSAIDs and so forth. But these are some drugs that you typically want to avoid combining with NSAIDs. Some of them because they increase the levels of certain drugs, and that includes things like lithium and SSRIs, and then others because they have additive effects on gastric mucosa or on bleeding, such as anticoagulants and antiplatelets. There are many limitations for the use of NSAIDs. We're going to highlight particularly GI toxicity and CV risk today. Also, I want to mention that asthma, about 10% of asthmatics are sensitive to NSAIDs and can see exacerbations of their disease when challenged with aspirin or NSAIDs. Renal injury, we know, is made worse by NSAID use, and we want to avoid NSAIDs for sure in chronic kidney disease 4 and 5. I also try to avoid NSAID use, or at least long-term high-dose NSAID use in chronic kidney disease at stage 3 as well. NSAIDs do have an effect on the liver, and patients with elevated liver enzymes or hepatitis C can have a worsening of their inflammation in the liver. Patients with cirrhosis can have increase in renal failure and other decompensation when given NSAIDs. Patients with congestive heart failure can experience exacerbations, and NSAIDs are contraindicated in the setting of coronary artery bypass grafting or severely elevated blood pressure. So let's talk for a minute about a drug called Vioxx. Vioxx, also known as Rifecoxib, was the first COX-2 selective NSAID. It was approved by the FDA in 1999 and marketed by Merck Pharmaceuticals, primarily under the brand name Vioxx. Rifecoxib became very popular, and over 80 million people were prescribed the drug at some point. And in 2004, Merck voluntarily withdrew the drug from the market due to concerns about increased risk of MI and stroke with long-term use. Merck withdrew the drug following disclosing that it withheld information about rofecoxib's risk for over 5 years, resulting in an estimated 88,000 up to possibly 140,000 cases of serious heart disease. In the year before its withdrawal, Merck recorded sales revenue of $2.5 billion from Vioxx. We'll talk a little bit more about the CV risk with various other NSAIDs. These are the black box warnings that the FDA has issued on NSAIDs, and this applies to all NSAIDs. The first details the increased risk of serious and potentially fatal adverse cardiovascular thrombotic events, including MI and stroke. The black box warning notes that the risk may occur early during treatment and may increase with the duration of use. The second black box warning notes that NSAIDs cause increased risk of serious gastrointestinal inflammation, ulceration, bleeding, and perforation, which could be fatal. Elderly patients and patients with a history of peptic ulcer disease or GI bleeding are at greater risk. And it again warns that these events may occur at any time during therapy and without warning. So I'm going to focus on the cardiovascular risk first. And there were 2 meta-analyses, both published in British Medical Journal, the first in 2011 and another in 2017, that showed that all NSAIDs, including naproxen, were found to be associated with an increased risk of acute myocardial infarction. Taking any dose of NSAID for 1 week, for 1 month, or more than a month was associated with an increased risk of MI. The risk of MI was greatest during the first month and at higher dosages. This graph shows estimates of rate ratios for possible comparisons between different NSAIDs. There's a lot of information on this slide, but if you will turn your attention to this top box, you can see that naproxen compared to ibuprofen favors the risk of naproxen being safer with all of these: myocardial infarction, stroke, and so forth. And as you look down the table, you see that naproxen is favored over diclofenac. Ibuprofen and diclofenac have some divergent data here, with myocardial infarction being somewhat favorable toward ibuprofen. And celecoxib seems to compare favorably compared to naproxen, ibuprofen, and diclofenac, which was contrary to the popular opinion at the time that COX-2 inhibitors carried a greater risk of coronary artery disease. Now, rofecoxib is here. That's Vioxx that we talked about. That drug was withdrawn from the market. And as you can see, the performance of rofecoxib actually tends to look about the same as celecoxib. So there's a lot of data in this graph. Some of it is somewhat confusing, but the conclusion from the meta-analysis reads, although uncertainty remains, little evidence exists to suggest that any of the investigated drugs are safe in cardiovascular terms. Naproxen seemed least harmful. Cardiovascular risk needs to be taken into account when prescribing any NSAID. Other data and studies have also supported the notion that naproxen and celecoxib both might be a little bit safer or have less harm in terms of myocardial infarction and stroke. So how about blood pressure? We talked earlier about how NSAIDs are recommended to avoid in patients with elevated or uncontrolled blood pressure. And we do know from multiple studies that NSAIDs on average increase blood pressure by about 5 millimeters of mercury. So this is something where in practice, if your patient is uncontrolled, if they're particularly stage 2 blood pressure, you might want to wait before prescribing. We're going to shift gears now and talk a little bit more about the GI injury aspect. Inhibition of COX-1 has multiple effects in the body, and with regard to the stomach, it decreases bicarbonate secretion, creating a more acidic environment. It decreases mucosal blood flow, and it decreases epithelial mucus production, which causes higher susceptibility to injury. In addition to these effects on COX-1, NSAIDs are acidic drugs, acidic medications, and they can directly damage the gastric mucosa. For this reason, when I'm counseling patients on proper NSAID use, I often recommend to them to take the NSAIDs not on an empty stomach and to avoid laying down right after taking. There are some strategies to reduce the GI toxicity of NSAIDs. When you can, use acetaminophen. You should be screening for H. pylori in patients prior to starting chronic NSAID therapy. In case you missed it, this was published in June of 2019 in the American Family Physician. And this was in the section called FPIN's Clinical Inquiries. The title of the inquiry is H. pylori Screening Before Initiation of Long-Term NSAIDs. And this article states that physicians should perform laboratory screening for and eradicate H. pylori before initiating long-term NSAID therapy in NSAID-naive patients to reduce the risk of peptic ulcer disease. And that carries a strength of recommendation A, which means it's based off of randomized controlled trials of high quality or meta-analyses. The same publication also states that physicians should screen for and eradicate H. pylori before initiating long-term NSAID therapy in any patient with a history of peptic ulcer, and that carries a strength of recommendation B. Other strategies for lowering GI toxicity include adding in a PPI to therapy or misoprostol, or switching to a COX-2 inhibitor such as celecoxib. Of the available NSAIDs, there are some that show a worse tendency toward GI toxicity and some with a lower toxicity. The medications listed on the left are the worst offenders that have the highest rates of GI toxicity. I don't tend to use those medications, with one exception being ketorolac, and we'll talk about that in a minute. Of the medications on the right have lower risk of GI toxicity. We'll spend more time talking about celecoxib and meloxicam here in a minute. So celecoxib, termed here the gut-friendly NSAID, is the only NSAID currently marketed as a COX-2 specific NSAID. That specificity for COX-2 makes it safer in GI, has less effect on lowering the gastric mucosa and bicarbonate secretion. It also has less drug-to-drug interaction with aspirin, meaning that it does not block the antiplatelet effect of aspirin the way that some other traditional NSAIDs, including naproxen, do. It also may have a lower risk of acute renal injury. However, celecoxib is among the weakest of NSAIDs in terms of pain control. In one study, only 40% of patients treated with celecoxib 200 milligrams per day reported at least minimal clinical improvement. And that was compared to a group taking naproxen 1 gram per day, of which 78% reported at least minimal clinical improvement. I'll also highlight another drug called meloxicam, and this probably deserves an honorable mention, but only in low doses. So in a dose of 7.5 or below, meloxicam has a higher specificity for COX-2. It behaves more like a COX-2, and it does not show as much GI toxicity. However, at the higher dose, 15 milligrams daily, it has a greater effect on COX-1, and it brings with it all the GI toxicities of other non-selective NSAIDs. Just for reference, the cost of meloxicam, which is now generic, is about $3 to $20 a month for the low-dose tablets. And this is often a good option for your patients with chronic osteoarthritis. This algorithm that you see here is out of the journal PM&R, and it was published in 2018 as part of a review titled Safety Considerations in Prescription of NSAIDs for Musculoskeletal Pain. This algorithm shows 5 arms. The first being both a patient who's both low for GI risk and cardiovascular risk, in which you could probably use any NSAID safely. Now, I still have my preferred NSAIDs that I use based on their proven safety profile and my familiarity with the drugs. In the second column, you have the patients with high GI risk, but low cardiovascular risk. So these patients would be those that have never had a prior MI or stroke, that have few or no cardiovascular risk factors, but perhaps they've had a prior peptic ulcer or prior GI bleed. These are patients in which we want to preferentially use celecoxib, which is the COX-2 specific NSAID, or low-dose meloxicam, such as 7.5 milligrams per day. And those would be the better choices in these patients. Again, you could also consider combining a PPI with those NSAIDs for added benefit. The third column shows patients that have high cardiovascular risk but low GI risk. These are the patients that probably cause us to worry the most when it comes to prescribing NSAIDs. We don't want to create or cause a heart attack. The odds ratio out of those BMJ meta-analyses for some NSAIDs is as high as 2, which means a relative doubling of coronary artery disease or stroke. And so these are not insignificant levels of risk. For these patients, if they're taking chronic aspirin therapy, this algorithm would recommend using celecoxib as preferred. And that goes back to celecoxib, the tendency that it does not block the antiplatelet effect of aspirin. Whereas patients who are not taking aspirin can use naproxen, again, the lowest dose, the lowest duration possible, but the naproxen is relatively safer than some of the other NSAIDs available. And then on the fourth column, you have high cardiovascular and high GI risk patients. And now with both of those being high risk, your compounded level of risk likely outweighs the benefits of using NSAIDs in those patients. In the last column, patients with known heart failure, recent coronary artery bypass grafting, or advanced kidney disease, we know that NSAIDs are contraindicated in those patients as well. So this table shows average monthly costs of several commonly used NSAIDs. And as you can see, they're all now generic. And the average monthly costs varies typically from a few dollars up to about $30, depending on the drug. I will point out at the bottom there that diclofenac gel, these prices of $16 to $25 are what I saw on GoodRx, but I will say that insurance companies do not universally cover diclofenac gel, and sometimes it will require a prior authorization or further documentation. It might be possible to just have the patient pay cash with a GoodRx coupon at the pharmacy. So before we end, I want to talk about a few special circumstances. And the first one is when you need an IV or IM NSAID. You all, I'm sure, have used ketorolac, also known as Toradol, and that is the only NSAID that's currently available in an injectable form. I want to note that the use is limited to 5 days due to its high risk of GI bleeding, and that stems from how it is so selective at blocking, inhibiting COX-1. Studies on effective ketorolac in postoperative pain show that it has no difference in efficacy between IM and IV routes. Both work, and it shows that it absolutely does have a positive benefit in reduction of pain. Side effects reported with ketorolac are common, and they include nausea and headache in more than 10% of patients, at least according to one study. I want to talk about the dosing of ketorolac, and I think one of our performance gaps that I have seen in our practice is that we probably need to be using lower doses of ketorolac. A study published in Annals of Internal Medicine in 2017 I'll highlight right here, is a randomized double-blind trial. It evaluated the effectiveness of 3 different dosages of IV ketorolac for acute pain in 240 adult patients between the ages of 18 and 65 presenting to an ED with acute flank pain, abdominal, musculoskeletal, or headache pain. This acute pain was defined as onset of less than 30 days, and patients were randomized to receive either 10, 15, or 30 milligrams of IV ketorolac in 10 mLs of normal saline. The trial pharmacist prepared the medication in identical syringes, and the syringes were delivered in a blinded manner to the nurses caring for the patients. Pain scores, vitals, and adverse events were assessed at baseline and at 15, 30, 60, 90, and 120 minutes. If the patients were still in pain at 30 minutes, IV morphine was offered. The primary outcome was numerical pain score at 30 minutes after ketorolac administration. The baseline pain scores were similar for all groups, 7.5 to 7.8 on a 10-point scale. All 3 doses of ketorolac decreased pain significantly at 30 minutes, with no difference between the groups. There was also no difference in the number of patients who needed rescue medication at 30 minutes between the groups. So this is consistent with known effect on the ceiling dose at which the maximum analgesic benefit is achieved, and suggests that the maximum analgesic benefit of ketorolac might be at 10 milligrams. I will point out that the FDA label provides for a maximum dose of 120 milligrams per day, and Hippocrates dosing lists giving 60 milligrams IM times 1 or 30 milligrams IM or IV Q6 hours in adults less than 65, which is substantially higher than the 10 milligrams in this study. A few caveats. Ketorolac is not widely available in a dose of 10 milligrams IV. In this study, it was prepared specifically by the pharmacist and is not readily available. And as you can see to the right, when we order it in Cerner, we have to pick between 15 milligrams or 30 milligrams. However, I would recommend, based on this study, that we choose 15 milligrams for our dose, or a lower amount if available. Second caveat is it is unknown whether the higher dose would have provided relief beyond 120 minutes, because the study did not measure beyond that time frame. I also want to talk briefly about topical NSAIDs. We mentioned diclofenac gel earlier. Topical NSAIDs are more effective than placebo for acute pain in superficial locations. They are indicated for large joint osteoarthritis and for small joint osteoarthritis in the upper extremities. The incidence of local and systemic adverse effects is similar to placebo. And so one available topical NSAID is diclofenac 1% gel. That is the generic of Voltaren gel. And that can be prescribed. It's used up to 4 times daily under typical circumstances. And I will point out that there is a 3% gel that is indicated for treatment of actinic keratoses. So how about pregnancy and lactation? The available data at this point shows us that ibuprofen, indomethacin, and naproxen are all safe to use in breastfeeding women. NSAIDs are not known to be teratogenic in humans and generally considered safe in pregnancy in low doses when used intermittently and when stopped 6 to 8 weeks before term. NSAIDs used closer to term can have an impact on the infant PDA, can lead to delayed onset of labor, and can cause fetal renal disease or oligohydramnios. So they should not be used in the late 3rd trimester. And of course, low-dose aspirin is generally considered safe to use throughout pregnancy. Quick plug here that early on in the course of the COVID-19 pandemic, many experts were saying not to use NSAIDs in patients with COVID-19 disease. The most recent available literature statement coming out of Europe says that there is not available evidence to suggest that the acute use of NSAIDs is related to increased risk of developing COVID or increased risk of more severe illness. So to summarize today, kind of what do I do? Basically, I avoid using some of the older NSAIDs or some of those that have greater GI risk, including indomethacin, flurbiprofen, ketoprofen, and the others that I have listed here. Some of these have shown greater GI risk. Some of them have shown greater cardiovascular risk, such as the case with diclofenac. Number two, I generally recommend over-the-counter NSAIDs in low-risk patients. I think these can be effective and useful, especially for acute musculoskeletal pain or inflammation. I generally recommend cautious use of naproxen for patients with known cardiovascular risk factors. I try to document the discussion of potential risks for MI and other cardiovascular events in the chart. And then lastly, I think it's helpful to be familiar with one NSAID from each class. So my go-to NSAIDs tend to be ibuprofen and naproxen in that propionic acid class. Nembumetone, meloxicam, and celecoxib are also NSAIDs that I have used for folks with chronic conditions such as rheumatoid arthritis or osteoarthritis. And then IV ketorolac is obviously handy in the inpatient setting or emergency department. And topical diclofenac, something that I haven't used much to date, but I'm going to try to start prescribing a little bit more, trying to use a little bit more topical NSAIDs when I'm able to. So bottom line, select your patients as appropriate for NSAID use based on their cardiovascular and GI risk factors. Prescribe the lowest dose and shortest duration to achieve the desired benefit. Use topical when possible. Don't forget to screen for H. pylori and treat with PPI, treat with eradication therapy prior to initiating chronic oral NSAID. And regularly monitor for possible adverse effects. I think when you start a patient on a chronic NSAID who is naive to that medication, it's important to see the patient back within a month to follow up on blood pressure, GI symptoms, edema, and consider checking a serum creatinine as well. So just to return to the case of Mr. Jones, Mr. Jones gets tested for H. pylori at your recommendation. He results negative. He has no other contraindications to NSAIDs, and you determine he has no cardiovascular risk factors. So you prescribe a trial of meloxicam, 7.5 milligrams daily, with follow-up in 1 month, as well as regular exercise. 1 month later, he notes a moderate improvement in his symptoms, and he's been able to get out and walk a lot more now that the weather's warmer. So Mr. Jones is happy, and you're happy too. You've avoided prescribing an opioid, and you've helped him to relieve suffering. This is the end of our talk today, and it's been great to have you with me, and I appreciate you tuning in. We had a few questions asked after the live session, and we were able to clarify a couple of things. We talked about the prior auth sometimes being needed on topical NSAIDs, and I built that into my earlier comments today. We also talked a little bit about balancing the risk with cardiovascular patients, and that's always an art, and that's where your clinical decision-making is paramount. With that, I thank you. I hope you have a great rest of this week, and please tune in next week. I plan to talk a little bit more about ulcer disease and PPI use. Thank you.